Alright, so our lecture today is going to be over stomach disorders, and I feel like this picture here perfectly illustrates all of the hazards there are, especially in modern society, to our stomach. And hopefully today we'll get to cover all these little things and try to, help you differentiate all the different types of stomach disorders. As usual, we have our instructional objectives to follow and help guide you along in your studying. And here's our outline for this lecture. So there are a lot of topics in the stomach, some of which overlap with the esophagus because they're next door neighbors to each other. And a lot of these diseases or disorders tend to overlap in how they present. So I'm really going to try today to help you notice the difference between them and understand how to approach each one, what special things to look for, and I will do my best to be as efficient as possible when going through this. So I think before anything, when you're studying ICM, one of the first things you need to do is be familiar with the anatomy. I'm not going to teach you the anatomy here, as it's a whole nother course, but I think this picture illustrates pretty well the way that the stomach looks, and you can see that the esophagus meets up here. We have the LES, lower esophageal sphincter, or the gastroesophageal junction here, and then we have the fundus, which is up here, the cardia, the body, the antrum, and then the pylorus. After that, we have the duodenum. So here we go. The first thing we're going to cover is dyspepsia, and if you can recall, we actually looked at dyspepsia a little bit in the esophagus lecture. And like I mentioned, some of these presenting symptoms, they tend to overlap with each other. And dyspepsia is one of those. So remember, if we can recall, dyspepsia is that, it reminds me of the Pepto-Bismol commercial. It's that nausea, heartburn, indigestion, upset stomach, bloating. Maybe not the diarrhea part, but everything else seems to fit pretty well. One of the other things is that epigastric type pain, heartburn, indigestion. It's kind of a catch-all term. It is extremely common. I see patients like this all the time in the clinic and in the ER, and occasionally it can actually be confused with angina because the pain tends to be kind of in that epigastric lower chest area. There are many etiologies for dyspepsia, as we discussed before, some of which are self-limited and sometimes self-induced. Usually the indigestion, where we overeat, we eat too quickly, we eat high-fat foods, or we're eating a lot during stressful situations, drinking too much alcohol or too much coffee, kind of the things we do to ourselves that cause these problems. That's some of the major etiologies. Other things that can cause dyspepsia are NSAIDs, and aspirin, and certain antibiotics, diabetes medications, all sorts of medications that can exacerbate or cause dyspepsia. Kind of the diagnosis of exclusion is this functional dyspepsia, which is essentially a non-ulcer dyspepsia, which has really no organic etiology. It's kind of its own thing. And you do all this routine testing, you've done endoscopy and everything, you really just cannot figure out why this person has dyspepsia, and we term that functional or non-ulcer dyspepsia. It's actually one of the more common types or causes of chronic dyspepsia, and it's a majority of the patients. Then we have all of the GI causes, kind of what we're going to be talking about today, which is peptic ulcer disease, GERD, gastritis, and then some of the other things which we'll touch on later on in our series of lectures. Other things that can cause dyspepsia are things like lactose intolerance, malabsorption, gastroparesis, and IBS. So it is kind of expanding or suspending the spectrum of causes. It's not just GI causes for dyspepsia. How do we make the diagnosis? Well, you kind of have to think about what is causing it and try to base your tests on clinical presentation and how it responds to empiric therapy. So when we think about it, and a lot of the things we're going to be discussing today, endoscopy really is one of the best tests of choice, and it is one of the first go-to tests for gastroenterologists because, as I mentioned before, it's a way for GI doctors to get in, to look with a camera into the stomach and get kind of a first-hand perspective of what's going on in the esophagus, the stomach, and the duodenum. So It is the test of choice for dyspepsia. Not every patient that has dyspepsia requires an endoscopy. I think that's something important to think about, is if every single patient that came in with dyspepsia got an endoscopy, we'd be doing a lot of unnecessary procedures. So we have to look at kind of general indications, right? So patients with alarm symptoms are those that like you cannot ignore. So weight loss, anemia, dysphagia, obstructive type symptoms. You cannot ignore those. You have to do an endoscopy. And what we're really looking for in endoscopy is not necessarily, because dyspepsia, you can maybe see it, but you're not looking, dyspepsia is a symptom. So we're looking for signs of strictures, ulcers, cancer, reflux esophagitis, and things of that nature. Other cases in which you should generally do endoscopy for patients with dyspepsia is, general rule of thumb is 60 years of age. I saw several resources that said kind of 55 to 60. Really use your clinical judgment on this, especially those with new onset dyspepsia, because if you're like me, I've had dyspepsia since I was in my 20s. I eat a pizza too late at night and I get this kind of in my stomach, But if someone comes to you, they're 60 years old, and they say, I have this feeling, this indigestion, this horrible in my stomach, I've never had it before, that is definitely something you'd want to look further into with an endoscopy. Other things, recurrent vomiting, evidence of GI bleeding, especially if it's upper GI, so hematemesis, the coffee ground emesis, or even melena. Those are signs of upper GI bleeding that you'd want to investigate further with endoscopy. Let's see, patients who don't respond to empiric therapy. So nowadays we have some pretty good therapy. PPIs are widely used. They're over the counter and prescription. And patients that you place on these medications that don't get better, that should be something that makes you want to look to see what else it could be, because they generally tend to respond pretty well. Also, patients with signs or complications of peptic ulcer disease or history of peptic ulcer disease, patients with recurrent symptoms, so they keep coming back despite what you're doing, and then, of course, any evidence of systemic illness, you should definitely look into dyspepsia more aggressively. So the diagnosis is, like I said, it's really not a diagnosis of dyspepsia. It's more trying to figure out what is causing the dyspepsia, if anything. And remember, we said that non-ulcer or functional dyspepsia is the most common cause. So not in all cases, we might not find the diagnosis, then we can kind of blame it on this functional dyspepsia. So kind of what we do is, if it's someone that doesn't meet any of the indications for getting an endoscopy, we tend to start by looking for H. pylori, because H. pylori is one of those things that can really cause these symptoms in patients, and it's easily detectable with the testing that we have nowadays. There's really 3 different types of tests we can do for H. pylori, and I'll try to go into this a little more in depth and we talk about H. pylori specifically. But essentially, you have the urea breath test, you have serological testing, which is blood test, and you have a stool antigen test. And in a little bit, I will tell you when to go with what test, because I know that can be a little bit, too many choices is sometimes not a good thing, right? Results, if you do, for dyspepsia's sake, if you find someone that has H. pylori, you treat it, right? If it's not, PUD is unlikely, because peptic ulcer disease is most of the time caused by H. pylori. You can think of other things that can cause the dyspepsia, like GERD, and you can treat empirically if they don't meet any indication for EGD. And then from there, if they get better, great. If they don't, then you might consider doing endoscopy. Other labs, so patients older than 60, you can't ignore it. You can't blame it on GERD. You can't blame it on something more benign. You kind of have to do the workup and exclude some of the more serious things like cancer. You get CBC, serum electrolytes, liver enzymes, calcium, thyroid function tests, and rule all that out, including an endoscopy, before you blame it on something more benign. Now, non-ulcer dyspepsia, like we mentioned, it's a diagnosis of exclusion. After all your testing is done, doesn't reveal a specific cause, that's what you can term it as. And dyspepsia symptoms have to be present for at least 4 weeks to make this diagnosis. Okay. How do we treat it? Well, it's the same thing as diagnosis. You kind of have to decide or figure out what it is that's causing it, or have an idea by history history and physical exam, although physical exam is not really that helpful in most cases. But anyway, you can treat the cause if it's known. So initial empiric therapy for patients younger than 60 years old with none of those alarm features would be things like proton pump inhibitors, H2 blockers, to try to see if we can get these symptoms under control. For all patients that are less than 60 and don't meet that criteria, but that respond or relapse after treatment, they should get an endoscopy. And that'll help rule out other things like peptic ulcers, GI reflux, gastroesophageal reflux, cancer, and when it's performed, they should get biopsies. And with those biopsies, they're going to look for cancer, they're going to look for gastritis, they also look for H. pylori infection. And if it's present with a biopsy, then you treat it. You're also kind of empirically, as far as treatment is concerned, you're going to advise the patient to do some lifestyle modifications, okay? That's always the first and easiest thing to recommend to your patient because it doesn't require a prescription. You just have to tell them what the best thing is to do. And, most patients know what they should be doing, and they choose not to because it's just not as fun. I know I'm completely guilty of that as well. But you should definitely advise the patient to avoid alcohol, caffeine, other foods that might irritate the stomach, spicy foods, foods with lots of red sauce. They should definitely stop smoking. Smoking doesn't help anything. Can also advise them to kind of raise the head of the bed when they're sleeping and avoid eating, especially 30 minutes before sleeping. And like we mentioned before, if you think or have a high suspicion that it is GERD or one of the other main causes of dyspepsia, you can try an empiric treatment of a proton pump inhibitor for a few weeks and have the patient back, see if it's helping. And if not, then endoscopy is your next step. And of course, if you do find H. pylori at any point in your workup for this patient, then you should treat it accordingly. We will cover that later on in this lecture. So that's our quick view at dyspepsia. Now we're going to go into some of the more specific GI causes of dyspepsia and heartburn and other things. So the first one, which is by far the most common, super common, is GERD. And like I said before, it kind of overlaps with the esophagus. So we kind of talked about it a little bit in the esophageal lecture, but we're going to really cover it more in depth in this lecture. And it's super common. I mean, if I could have you guys show a raise of hands of how many of us have had GERD at one point in our life, I think a lot of us would raise our hands, myself included. So the general characteristics, it's multifactorial. Essentially what it is the inappropriate relaxation of the lower esophageal sphincter, so decreased tone. And you get retrograde flow of stomach contents, so acid and other things, up into the esophagus. It splashes up in there. That esophagus is not well equipped to withstand the acidic nature of stomach contents. And so you get decreased esophageal motility also, or that can contribute to it. If you have a gastric outlet obstruction, that's definitely not helping because you're having more backup of acid in the stomach. Hiatal hernias are common. They say maybe a fourth of patients with non-erosive GERD have hiatal hernias. 3/4 of the patients with severe erosive esophagitis and over 90% of patients with Barrett's esophagus have hiatal hernias. So it's very, very common to have that with GERD. Other things that can contribute to GERD are dietary factors, right? So alcohol, tobacco, chocolate, high-fat foods, coffee, anything that really decreases the lower esophageal sphincter pressure, and it can exacerbate the condition. Other thing like truncal obesity, so being overweight and being pregnant, those things can also exacerbate or cause GERD. And it's very, very common. You will see it. You'll see it in urgent care. You'll see it in primary care. You'll see it in ER, and you'll see it all the way from younger folks all the way up to old people. So the prevalence definitely increases with age. As everything kind of relaxes in our body, we lose elasticity, we have an increased prevalence of GERD. How does it present? It is heartburn. If you hear someone come in and they say they have heartburn, you should think GERD. Not only GERD though, but it should be one of the first things that pops in your head. Usually they describe it as like this retrosternal, this burning. It's usually shortly after eating, especially large meals, and it tends to come on about 30 to 60 minutes after meals. It's definitely exacerbated by laying down after meals. So if you eat a big meal and then you go try to take a nap on the couch, you might feel this kind of whoop, everything coming back up. And patients usually kind of point to their chest area and kind of run their hand up and down when they describe it. Body language is very important when you're taking a history on a patient. When heartburn is the dominant symptom, when they come in and say, I have heartburn, you can really rely on that, right? That's a really high degree of reliability that it is GERD. However, I say that with a caveat. If the patient is older or has cardiac risk factors, you need to work up ischemic heart disease because they can mimic each other really closely. I actually knew someone, an older gentleman with diabetes and high blood pressure and stuff, that had GERD and kept describing, I just keep getting this heartburn. I keep getting this heartburn. He was taking Nexium and all sorts of other medications. Just never got better. So he finally went to the doctor. They did EKG. It was a little abnormal, and they figured that he had vessel disease in his heart. He's actually feeling what he thought was heartburn, but it was actually angina. So you do have to be careful. You can't always hang your hat on GERD just because they say heartburn, but it is more common to have that, okay? Other things that they present with: dyspepsia, like we talked about, regurgitation. Just reading the word water brash is like talking about lemon sours. It just makes my salivary reflex start happening. And really what it is this like excessive salivation that people get, this hypersecretion with GERD. If the GERD makes it, or the reflux makes it all the way up to the throat, you can actually also get this cough. You can get hoarseness, sore throat, feeling kind of a lump in their throat. And then patients can also get early satiety, postprandial nausea, even vomiting. And then dysphagia. If you have dysphagia, that's a pretty severe symptom. 1/3 of patients tend to get it, and it's usually due to erosive esophagitis, like we talked about in the esophagus lecture, where that acid kind of eats away at the esophagus and it becomes very inflamed. And they can also develop strictures. So if patients have dysphagia along with GERD, probably need to do an endoscopy to look for strictures and other things, okay? Now, history and physical exam. History is pretty helpful, but history and physical exam are usually normal in uncomplicated disease, and clinical diagnosis is only about 65% sensitive and specific. So if you need to do some workup, do it. How do we work it up? Well, diagnostic tests are not always necessary. If you have typical uncomplicated GERD in a young healthy person, you can try treatment before you go looking for something. Tests are indicated in atypical, complicated, persistent cases, kind of like what we talked about for dyspepsia, right? So endoscopy should be performed if they have any type of alarm or worrisome symptoms. Those are the same things we talked about: anemia, weight loss, dysphagia. And what we want to do is an endoscopy with biopsy. Now that's a procedure. We go in with a camera and we take samples and look at what the stomach, esophagus, and duodenum appear under camera. And this is the test of choice for diagnosing GERD. It is not always necessary, but we definitely has a role in diagnosis, especially if you have refractory GERD. GERD should get better with treatment. Let's see. Upper GI series or barium contrast study, we really don't do those very often, especially in GERD. We tend to do the endoscopy with biopsy. We cannot diagnose GERD with an upper GI series. It's kind of an old school procedure. One other thing that we do, it has a role in GERD, is a 24-hour pH monitoring, where they stick a probe down and it measures the acidity in the esophageal / stomach area. Now, this is considered the gold standard for diagnosing GERD, but it is not the one that we do most often by any means. This is usually reserved for patients that have kind of an unsatisfactory response to empiric therapy, or they have atypical extraesophageal symptoms, or maybe if they're being considered for reflux surgery, then they would use the 24-hour pH monitoring. But it is definitely not used routinely. Last but not least, not necessarily for the diagnosis of GERD, but really for ruling out other motility disorders, an esophageal manometry can be done. So you can see that there's kind of a handful of tests that we tend to do for these different upper GI problems, but trying to decide which is most indicated is a little tricky. Hopefully by the end of this lecture we'll get a better grasp of what we usually do. So complications. GERD by itself is really not so bad. You treat it, you use some PPIs or H2 blockers, and it gets better. Tends to kind of wax and wane over time. But there are things that can be more complicated when it comes to GERD, one of which is erosive esophagitis. This is what we talked about in the esophageal lecture. This is when you have that acid that's creating inflammation of the esophagus. It can be seen on endoscopy. And these are the type of patients that tend to develop strictures, ulcers, Barrett's, and they're candidates for long-term PPI use. Like we said, you can develop strictures. It's where that, I think of it kind of as like scarring down or kind of tightening within the esophagus from the GERD. You can also get it within the stomach itself, which can have trouble with food passing out of the stomach. You can get esophageal ulcers. You can get Barrett's, which we talked about in the esophageal lecture, especially with reflux or GERD is the primary cause of Barrett esophagus, which can then lead to adenocarcinoma. We talked about screening and surveillance for Barrett's in the esophageal lecture. This would be a good time for you to brush up on that. Patients can also with GERD get recurrent pneumonia. You get this aspiration coming from the fluid that comes up into the back of the throat. And if we have the type of GERD that gets all the way up to our mouth or our oral pharynx, you can actually get dental erosion, laryngitis, and pharyngitis, which is not cool to think about. The GERD, how do we treat it? Well, like we said before, one of the major things that we can recommend to our patients first and foremost is behavior modification. And it mainly has to do with diet, weight loss, stopping smoking and drinking, avoiding fatty foods, coffee, orange juice, chocolate, avoiding large meals before bedtime, elevating the head of the bed. It's a chronic disorder. So we're asking patients to make these modifications for the long term, which is pretty difficult to do. These patients do require kind of regular follow-up and monitoring and tinkering with medications. So if you have mild GERD, mild disease, you can start with H2 blockers. And now H2 blockers are going to be like your over-the-counter Zantac, Pepcid kind of medications. And those can be used in addition to antacids for mild intermittent symptoms. I'll tell you this, after working in a GI clinic, I'll say that a lot of patients have tried H2 blockers over the counter since it is so readily available. So by the time they make it to you, even in primary care, they're probably looking for something a little stronger than an H2 blocker. However, if this is the patient that gets occasional GERD, like after they eat pizza, and that's pretty much it, then you can recommend, hey, 30 minutes before you eat that pizza, go ahead and take that H2 blocker or pop some antacids before. We could recommend that. By far, the most effective means of treating GERD is going to be proton pump inhibitors, PPIs, and they tend to be very safe. They're treated once a day orally, and they tend to be preferred over H2 blockers and antacids as the initial treatment. Those who achieve good symptomatic relief, they can be discontinued. We usually give it a couple months to kind of kick in, get symptoms completely gone. And then after that, it can be reevaluated and decide if we want to continue on them or if we want to kind of wean the patient off of the PPI. But the thing about it is it's a chronic disease, so more than likely it's going to come back unless it's caused by situation. So if you're pregnant, and the reason you have GERD is because you're pregnant, and having the baby likely gets rid of the GERD, right? You don't have to be on medication long term. So it does require, like I said, some tinkering. So you can, after you reach that symptomatic relief, you can take them off the medication, see if it comes back. If and when, which it usually does, come back, then you can decide to do either continuous therapy, this intermittent therapy where you do a few weeks course and then stop and then reassess, or you can do on-demand treatment. Now, be mindful that PPIs don't work instantaneously. They do take a day or so to kind of kick in. So this is not the kind of treatment that you want to give a patient like for acute, like got to get rid of it now because I can't sleep kind of pain. It tends to have kind of a cumulative effect. Unresponsive disease. So up to a third of patients report inadequate relief with once a daily PPIs. You can actually, these are the kind of patients you want to refer to GI. You shouldn't have to be upping PPIs to more than once a day in a primary care clinic. There might be something else going on. We tend to bump it up to maybe twice a day, and we tell them to take it like 30 minutes before breakfast and 30 minutes before dinner. Patients that are unresponsive to that, they need, if they haven't already, they need to undergo endoscopy. We're looking for other things, eosinophilic esophagitis, achalasia, that can mimic GERD, and then truly refractory esophagitis. It can be caused by medical noncompliance. Maybe they're not taking the medicine correctly. Patients do develop kind of a resistance to PPIs over time, or it can be something like Zollinger-Elison Syndrome. So we don't want to ignore refractory illness. We want to kind of take a closer look. For severe and resistant cases, kind of the end game treatment, or what we can do kind of as a means to try to fix the problem, is corrective surgery. And the indications for surgery are kind of what we just talked about: intractability, severe problems, and severe esophageal injury, so ulcers, strictures, Barrett's. And the type of surgery, similar to what we talked about in the esophageal lecture, are the Nissen fundoplication, which is pictured here. So this is the Nissen fundoplication, where you take the fundus of the stomach, you kind of wrap it around and sew it together, and that kind of tightens up the lower esophageal sphincter so that acid isn't able to come up. We can also do partial fundoplications. And then if a patient is severely obese and they're having significant GERD, you should really consider doing gastric bypass rather than just the Nissen fundoplication. And really, patients have pretty excellent outcome with this. Greater than 80%, 85% have excellent relief. And then typical reflux symptoms do tend to recur about 10 to 30% of patients, but at this point they are usually managed well by the addition of PPIs. All right. So we are going to talk now quickly about the two types. We've been talking about H2 blockers, PPIs. These are pretty recognizable medications, things that you've seen either on commercials, in the store. One thing I do want to mention here is this: it is not ranitidine anymore. So ranitidine was found to have some cancerous issues, and so Zantac actually reconfigured and is actually famotidine, just like Pepcid. They are both found over the counter. I don't tend to see this one very often, nor this one, but they are available as well. PPIs, most of these are now over the counter. So Nexium, Prilosec, OTC. I'm not sure about Prevacid, Protonix, and Acifex, no. And then Dexilant is the one that we tend to use in the GI clinic. It's kind of our last resort and considered to be kind of the strongest PPI that we have. All right. So when should you, as a primary care PA, refer for GERD? Well, we've already kind of talked about a lot of them. Alarm symptoms, patients that aren't resolving with empiric management, patients that require an endoscopy for any reason, patients with Barrett's esophagus that require surveillance, and if surgical therapy is considered. Now, if you're like me and you love algorithmic approaches, these are the approaches to initial management of patients with GERD, and then management of GERDs who fail PPIs. I'm not going to go step by step through this, but if you are one that likes to know, like, well, when do I use an H2 blocker, or when should I use a PPI as first line, I'm kind of confused. This will help you kind of work your way through it. So I'm going to leave these here for you to look at on your own. So next up is gastritis or gastropathy. They are not the same thing, but they are close. So a gastropathy is essentially what you would see on it's damage that you would see on pathology or on endoscopy when you look at the stomach, but it's without inflammation, whereas gastritis shows evidence of inflammation within the stomach. Now, it doesn't really matter to us too much because symptomatically they're going to appear pretty similarly. And gastritis is one of those diagnoses that is hard to make clinically, but a lot of patients think they have it, especially down here in the Rio Grande Valley. I have a lot of patients coming in, pues tengo gastritis, I have gastritis, without any formal diagnosis. Essentially what it is inflammation of the stomach, and there are kind of these three categories. So there's erosive or hemorrhagic gastritis, non-erosive or non-specific gastritis, and then you have these specific types, which I'm really not going to go into for the purposes of this lecture. Overall, you'll see this recurring theme between GERD, dyspepsia, gastritis, and peptic ulcer disease. The same culprits over and over and over again. So gastritis can be caused by infection, like H. pylori, by inflammation, chronic NSAID use, alcohol, physiological stress, so patients that are under high stress in like ICU with sepsis, burns, renal, hepatic failure, or that are intubated. You also have it in autoimmune hypersensitivity problems, and then sarcoidosis, Crohn's, and then other various infections and things. So it kind of runs the gamut. So we're going to talk briefly about the erosive hemorrhagic gastritis and a little bit of the non-erosive, non-specific gastritis. So general consideration. So most common causes of erosive gastropathy are going to be medications, especially NSAIDs, and alcohol or stress due to medical surgical illness. Okay. Major risk factors include mechanical ventilation, trauma, burns, shock, sepsis, all sorts of things. And that's why we tend to put patients that are admitted to the hospital on GI prophylaxis, which includes a PPI. Clinical findings, they're kind of similar to what we've already seen. It can be asymptomatic, but they can get the same thing: epigastric pain, anorexia, nausea, vomiting, and then GI bleeding. So gastritis can cause significant GI bleeding. Okay, because erosive gastritis is superficial, bleeding is pretty rare, but we still can see it. And remember that upper GI bleeding is usually seen as either bright red blood, coffee grounds, or melena, so dark tarry stools. And the thing about it is you have to ask specifically about melena because patients don't always realize that black stool is not normal. So you should definitely ask your patients about that. Laboratory findings going to be pretty non-specific. You're going to want to get an H&H to see if your hematocrit is low, which would be indicative of, significant bleeding over time. You can also get fecal occult blood to look for blood in the stool that's maybe not seen by the naked eye. And if you have enough blood loss, the iron deficiency can be found. Really, upper endoscopy is the best test for gastritis, for diagnosing gastritis. Back in the day, they used to do the upper GI series, which is the barium stuff, but we really don't do that anymore. We usually do the endoscopy. Okay. So treatment really depends on what's causing it. So stress gastritis, like we talked about, patients in the ICU, patients with burns, critically ill, you're going to want to prophylax these patients, okay? Because they can develop stress within 7 to 2 hours of being admitted to the hospital. So these are the patients that you want to start on IV, H2 blockers, or proton pump inhibitors. And it's usually part of admission protocol, especially for ICU patients. Now, instant gastritis seems pretty straightforward, right? We want to try to eliminate NSAIDs from their regimen. However, in some cases you can't. I mean, these patients are taking NSAIDs for a reason, usually chronic pain, osteoarthritis. And so if you can, you want to move them over to something that's not NSAID based, like maybe acetaminophen. But if it's not, then you have to try to get them on a regimen that they can take a lower dose and take a PPI or some sort of medication that'll help them achieve kind of this homeostasis between the two. Of course, if they have any alarm signs or symptoms, you have to get the upper endoscopy to look for other causes. Want to try to discontinue it. If you can't, reduce it to the lowest effective dose and try to get them to take it with meals to kind of buffer that medication. And that's pretty much it. Alcoholic gastritis, of course, if we can, we want to safely get the patient off the alcohol. And it's not actually proven, at least scientifically, that alcohol alone causes significant erosive gastritis, but we tend to see those dyspeptic type symptoms with alcohol consumption, especially excessive alcohol consumption. So we try to wean the patients off their alcohol and then place them on therapy as needed. One other thing I want to mention is kind of some buzzwords when it comes to stress gastritis are these ulcers that can occur in stressful situations. There's two that tend to pop up kind of recurrently that I wanted to mention just as for thoroughness sake. These are ulcers caused by stress ulcers. I know we haven't started talking about ulcers yet, but they tend to be kind of like the next step after gastritis. So gastritis is inflammation of the stomach, kind of widespread inflammation of the stomach, whereas ulcers are these erosions in specific parts of the stomach. It's kind of like the next step, right? So there's two that tend to pop up. One is Curling's ulcer and the other is Cushing's ulcer. Now, Curling's ulcer tends to happen in patients with severe burns. And that is because with severe burns, you get this massive hypovolemic shift, and that tends to cause ischemia in the stomach. And so when you get ischemia in the stomach, you get inflammation in the stomach, you get gastritis, and eventually can get these ulcers. And the way that osmosis likes to help you remember it, which I think is really cute, is a curling iron burns, right? So you get severe burns. Cushing's ulcer, on the other hand, is seen in patients with brain injuries, specifically patients that have like increased intracranial pressure. What happens is when you get that increased intracranial pressure, you get overstimulation of the vagus nerve, which increases gastric acid production, and thus causing stress in the stomach, ulcers, and gastritis. And the way that they like to get you to remember Cushing's is that you have bubble wrap around your brain. So your brain needs a lot of cushion. And this is a nice little helmet, protective helmet. So that's how they get you to remember it. These are just kind of like, if you remember it on your test, you get it right. If you don't, well, that's too bad. But hopefully these cute little images help you remember Curling's ulcers and Cushing's ulcers caused by stress. The second category in gastritis is non-erosive, non-specific gastritis, is characterized by certain histologic inflammation. It's more like what you see when you get those biopsies on endoscopy. Really not so important to differentiate the non-erosive from the erosive kind, because essentially you're going to do the same workup and the same treatment. The only thing that's different is if you have H. pylori. So we're going to talk next about H. pylori. We're going to talk about H. pylori infection in general, not just how it applies to gastritis, but how it applies to gastritis and peptic ulcer disease. Okay. Other things that can cause this type of gastritis are pernicious anemia, which you guys probably talked about with Dr. A back in the immunology hematology module. Essentially, it has to do with B12 and intrinsic factor, and you get this gastritis. I'm not going to talk about it too much. And then eosinophilic gastritis is similar to eosinophilic esophagitis, except it's in the stomach. And there's some other genetic environmental factors, which I am not going to go into for this lecture. So what is H. pylori? Not just gastritis, but infection. I'm going to write that here so we remember. So it's a gram-negative rod, looks like this up here. We tend to see it kind of in the stomach, but it can cause mucosal inflammation. And in developing countries like the US, the prevalence is actually rapidly declining. So we're tending to see this less and less. The transmission is from person to person. It's not completely well understood how it's transmitted. We think there's some components of fecal oral, oral, And we tend to see it like with kids between infancy and childhood, where they kind of pass it from one to another. So it can be essentially contagious. But acute H. pylori, so you get this kind of transient illness with a nausea, abdominal pain, lasts for a few days, and it kind of progresses onto this more chronic problem. It can be completely asymptomatic. People don't even know that they have H. pylori. Or you can get this kind of diffuse gastritis or even peptic ulcers that can develop from it. We tend to see more in the duodenal and gastric ulcers it can cause. And we'll talk about that a little bit more. It's estimated that for as far as gastric cancers, the H. pylori is accountable for 80 to 89%. So it can be one of the major risk factors for gastric cancer, which is not a very common cancer here in the United States, but we will talk about that in a little bit. So how do we test for it? So I think this is a good time to really go into the different testing for H. pylori. So there's non-invasive testing and more invasive testing, which is essentially endoscopy. But when we talk about non-invasive testing, we're going to talk about 3 different tests. First, serology. Second, urea breath test. And 3, fecal antigen immunoassay. Serology is not as accurate. It's quicker and easier, and it's less expensive. It's a blood test. But the thing about serology is it is less accurate, and if you've had H. pylori before or you've recently been treated for H. pylori, your serology is going to stay positive. So it's not a good test to do if you've had remote history of H. pylori or if you're trying to see if a patient is resolved after treatment. It's not good for that, okay? 2 of the tests that we tend to use more often for diagnosis and for resolution of H. pylori are the urea breath test and the fecal antigen test. So the urea breath test has excellent sensitivity and specificity. It's really good, 90-95%. The fecal antigen is in the same ballpark. And one is by breath. So this is the urea breath test. You get this little bag and you have to blow into it a few times. It does take quite a bit of time, and it is a little more expensive, but it's very, very accurate. And then the fecal antigen immunoassay, you have to have the patient provide stool, and we use that for testing. Now, for both of these 2 tests, it is recommended that the patient not take their PPI for 14 days and antibiotics for 28 days. For whatever reason they were on antibiotics, or if they're on PPIs, it can really reduce the sensitivity of the test. So we have to discontinue them for at least 14 days. Okay, that's something to keep in mind in those patients that have pretty severe disease. And then probably the best test, if we had to choose one, although it is invasive and we don't always have to do it, is endoscopy with biopsy. So for those that have those alarm symptoms that we have to do the endoscopy on, or they're older patients, we can get the biopsy, and that will show us H. pylori, and it's greater than 95% sensitive and specific. It's a really good test to do. So most of the time what we do, this is treatment. Most of the time what we do is either the urea breath test or fecal antigen, depending on what we have readily available in the office or what the patient wants to do. Some patients don't like collecting their stool. We do that. It comes back positive in a patient with no alarm symptoms that has no other risk factors. If that comes back positive, we treat them. Okay. If the patient is older or they have some other dysphagia or some other alarm symptom, then we tend to do the endoscopy, and that will tell us whether or not they have H. pylori. Once they have had the H. pylori treatment and we need to test them again, we use either urea breath test or fecal antigen. I think what we usually did in our clinic is the fecal antigen to make sure that it was eradicated. It's just send out easier to do than having them sit there and in the office and do the lengthy urea breath test. That's what we did in our office. Here's the treatment for H. pylori, and I do want to kind of point something out here. Classically, the treatment has classically been standard triple therapy. But it is actually no longer recommended as the #1 treatment because of pretty significant widespread clarithromycin resistance. So here's up-to-date approach to H. pylori treatment. If any of the following are present, so prior exposure to macrolides or local clarithromycin rates greater than 50%, which I am not 100% familiar with our local rates, but most places have resistant rates greater than 15. So unless local data otherwise indicates, it's going to be a yes, and you're going to want to do the quadruple therapy. Okay, we tend to do the quadruple therapy all the way around. Okay, if for some reason you end up working in an area that doesn't have that, you can then assess for penicillin allergy and whether or not they've used metronidazole, and then you can do a triple therapy or quadruple therapy. Okay, so the standard quadruple therapy is going to be this here, and it's going to be quad, 4 drugs. It'll be a PPI, bismuth, tetracycline, and metronidazole. Or you can do these right here that has like an all-in-one medication. Okay, and this is a 14-day treatment. After which you would then retest and see if you've eradicated. So after completion, you would then want to continue treatment with just a PPI to try, especially if they have an ulcer that's large. And then you want to concur or confirm eradication with urea breath test, fecal antigen, or endoscopy with biopsy, which not always necessary. Okay, so there we go. That's how we treat it. And it's a perfect segue into peptic ulcer disease. Now, we have been sitting here for a little over 45 minutes. So if you need to take a quick break, now would be a great time to get up, stretch your legs, go get a snack, and then come back and we will finish up this lecture. We are on slide 29 of 58. There are a few pictures hidden away, so we're about halfway there. All right. All right, coming back, we have peptic ulcer disease, okay? We just finished talking about H. pylori and gastritis. Peptic ulcer disease is kind of like that next step. It's when we start getting erosion inside the stomach, okay? So the most common causes are things that we have just talked about over and over again, but we are mentioning them again. We have H. pylori, NSAIDs. We have these other conditions. So these two are by far the most common causes of peptic ulcer disease, H. pylori and NSAIDs. Okay. Other conditions can be things like Zollinger-Elison, CMV, Crohn's, or idiopathic, but these are much, much, much less common, only 5 to 10% of ulcers caused by this. Other things that kind of contributing factors, smoking. Patients that smoke are twice as likely to get ulcers than in non-smokers, so it is a contributing factor. Smoking alone doesn't cause peptic ulcer disease, but it certainly contributes. Alcohol and coffee, they do say can cause ulcers, but there really is no specific proven association, but there is a causal relationship. So other things that are kind of unproven, but you kind of tend to see them together, are emotional stress, kind of this type A personality, and other dietary factors. Just things to think about. So H. pylori associated ulcers. We already talked about H. pylori infections, but specifically with ulcers, gastritis and H. pylori are the major of duodenal and gastric ulcers that are not associated with NSAIDs. So ulcer disease, whereas they're the major cause of peptic ulcer disease is uncommon in H. pylori. Let's talk about that again. So peptic ulcer disease is majority of the time caused by H. pylori, but a lot of patients have H. pylori and only about 10% of them actually develop ulcer disease. Hopefully that makes sense. The prevalence of H. pylori is up to 70 to 90% in duodenal ulcers. Because when we talk about peptic ulcer disease, I guess one thing I should mention up front is we talk about two things. We have gastric ulcers and duodenal ulcers. I'm just going to put duodenal ulcers. And really, it's not too important for us to know whether it's gastric or duodenal, because either way we treat it and diagnose it the same. But classically, there are some things that point more to gastric or duodenal, and I have a chart that I'll show you in a little bit. But just so we know, peptic ulcer disease means gastric and duodenal ulcers. Duodenal ulcers, 70 to 90% of the time have H. pylori. Crazy, right? And in gastric ulcers, a little bit lower H. pylori, but it's by far the most common cause when NSAIDs are not implicated. Okay. Now, after successful eradication of H. pylori with the quadruple therapy that we just talked about, ulcer rates go down to 5 to 20% a year. Most of these recurrences are due to NSAID use, or rarely do you get reinfected with H. pylori. Now, NSAID ulcers is the second most common cause of peptic ulcer disease, 10 to 20% of prevalence in gastric ulcers, and 2 to 5 of duodenal. Okay, so it is more commonly causing gastric ulcers. Most NSAID ulcers are actually asymptomatic, but the risk of getting NSAID ulcers is greatest within the first 3 months of initiating therapy. And then, of course, those that are older, have prior history of ulcers, or who take NSAIDs in combination with aspirin, steroids, or anticoagulants. This is what peptic ulcers look like. Remember, we could get them in the stomach, or we can get them in the duodenum. Okay, and they erode. They're like little ulcerations in there. Clinical features. You're going to notice that the clinical features are very, very similar between GERD, gastritis, peptic ulcer disease, and dyspepsia, right? And that's okay, because the good thing is that we tend to work these patients up the same way. Okay, we're looking for the same things. So it's okay that we can't always clinically diagnose these. Okay, we're going to typically see this dyspepsia or epigastric pain. This is the hallmark of peptic ulcer disease. 80 to 90% of patients complain of this. They complain of this pain, kind of this aching or gnawing pain, this hunger pain that they get in the pit of their stomach, and also can get these nocturnal symptoms. And food can affect ulcers certain ways. Now, there are some, classic presentations of ulcers. But they can be very variable from patient to patient. So it says in the textbook that approximately 50% of patients report relief of pain with food or antacids. And usually what we see is with gastric ulcers, so the ones in the stomach, we tend to see it get worse after eating. Within 30 minutes after eating, it gets worse. But when we see the duodenal ulcers, they tend to get better initially after eating. And then 2 to 4 hours later, they get worse. Now, why is that? Why do we think that? Well, if we think about how digestion happens, let's use this little stomach guy as our friend. So we get food, it comes into the stomach, and it has to stay in the stomach and get churned around, right? It gets churned around in here for a period. And during this period of time, shortly after eating, this pyloric sphincter clamps down and prevents acid in stomach contents from going into the duodenum. So you can imagine if you had an ulcer here and you eat, and this closes off, you're going to feel some relief. So that's why these patients tend to feel better after they eat. Now, if you have an ulcer smack dab in the middle of your stomach and you eat, all that churning and acid production is going to make that feel worse. And that's why gastric ulcers tend to be worse pretty close after starting to eat, and duodenal better than worse. Not that it really matters when you diagnose it because you're going to treat the same way, but they love to test on this. So I'm just mentioning it so that we can all be on the same page when it comes to this. They can be complicated by GI bleeding, right? We have an ulceration. These ulcerations can ulcerate or erode down into vessels, which can cause significant bleeding. It can cause nausea and vomiting, early satiety, and weight loss. Because remember, if we eat and every time we eat it hurts, tend not to want to eat. Okay. Physical exam tends to be normal, uncomplicated peptic ulcer disease. He gets kind of this mild epigastric tenderness on deep palpation. And then also on a fecal occult blood test, we can get a positive result because of this bleeding that happens that we can't really see. It can be microscopic in the stool. Good. So how do we diagnose peptic ulcer disease? Well, we get an idea clinically, but the most accurate test is going to be, again, an EGD, endoscopy. So if you notice, between regular old dyspepsia, GERD, gastritis, and now peptic ulcer disease, we do endoscopies to make the diagnosis. So you can see why it's not vital that we make this profound diagnosis before we look, because looking is kind of what tells us, which I love about GI. The diagnosis of gastric ulcers is made by endoscopy because the biopsy is necessary to rule out malignancy, right? Duodenal ulcers don't always require biopsy, but we tend to do biopsies anyway. Especially when we have GI bleeding, we want to go take a look. What is causing the bleeding, okay? And they can also do electrocautery or cauterize the bleeding ulcers at that time. At the same time, remember, we're also looking for H. pylori. EGD is perfect opportunity to look for that. Back in the day, we used to do a lot of barium swallows. We really don't recommend it nowadays in the workup of peptic ulcer disease. It has limited utilization in patients with dysphagia or patients that we think the ulcers are caused by something else. Abdominal CT is used, especially in patients with complications of peptic ulcer disease, like perforation, penetration, obstructions that can happen because of recurrent ulcers. So it has some limited use. And then also what's not listed here is an upright chest x-ray or an acute abdomen series. So an upright chest x-ray or acute abdomen series. And that's an x-ray that's done to look, get a quick look at the abdomen. And I'm going to tell you about this in just a minute when we talk about complications of peptic ulcer disease. Okay, so be ready for this. It's coming up. Okay, laboratory tests. So uncomplicated peptic ulcer disease are not going to show anything as far as labs are concerned. If you have this kind of chronic bleeding, you can get anemia. You can get some leukocytosis, especially if you get this penetration or perforation. Remember, if you have an erosion and in the lining of the stomach, eventually that erosion can erode straight through and cause a perforated viscus, a perfed abdomen, perforation in the stomach, which is not good. Bacteria gets in there, you get peritonitis, and the patient can get fever, extremely ill, rigid abdomen, and die. We'll talk about that in a minute. We also need to diagnose, as far as laboratory testing, H. pylori, especially if we don't elect to do the endoscopy first off. And those are done by biopsy if we have to, urea breath test, serology, or fecal assay. Okay, we already talked about that. If we have recurrent peptic ulcers or recurrent GERD that's refractory to treatment, we should also consider getting a fasting serum gastrin measurement, and that's for Zollinger-Elison. And we'll talk about that in a minute as well. How do we treat peptic ulcer disease? Well, we've kind of already talked about the major treatments. The good thing for peptic ulcers is it's very similar treatment, again, to GERD and to gastritis, right? So the medical treatment, majority of the patients can be successfully treated by treating H. pylori. Remember, we said the majority of cases of peptic ulcer disease are caused by H. pylori. So treating the H. pylori tends to get rid of the ulcers. If it's NSAID-induced, avoiding the NSAIDs helps. And then using these other drugs can help. As with the other conditions, recommending supportive care, like discontinuing the NSAIDs, restricting alcohol, stopping smoking, decreasing stress. Although I don't know how it's possible to decrease stress. Send me on a vacation to the Bahamas or something, but I mean, that's more expensive than starting on PPIs. Avoiding eating before bedtime, decreasing your coffee intake. I can't tell you how many times when I worked in GI, I had to tell patients over and over again, limit your coffee. How many cups of coffee do you drink a day? Oh, 4 or 5. Oh, and you have GERD? Yeah, okay, we need to reduce that. What about chocolate? Oh, I love chocolate. Okay, well, we should reduce that. What about alcohol? Okay, I have 2 or 3 drinks before bed. Well, we need to limit that. What about smoking? Okay, smoking. Gotta talk to patients. Gotta ask them. Gotta find out about them to help them help themselves, okay? Drugs are the same kind of drugs we've already talked about. So we have anti-secretory. We have mucosal protective agents, which we haven't talked about yet, but we will. And then the eradication of H. pylori, which we already discussed. So anti-secretory agents are going to be PPI, and PPIs are the preferred agents for peptic ulcer disease. Now remember, this is not just GERD. This is an actual ulcer. So we do want to start with PPIs for ulcers. It provides fast relief and more rapid ulcer healing than H2 blockers. And so we don't use H2 blockers nearly as much as we do PPIs. Other agents, these mucosal defenses, right? So it kind of defends against the excess acid, is sucralfate. And I had some patients in GI clinic that would use it that just swore by it. It's like this viscous type liquid that kind of coats the esophagus and the stomach and helps provide kind of a barrier between the acid and the stomach. Although it can be costly because it has to be taken so frequently, and it can also cause some GI upset. So I tend not to. It's not one that we use first line by any means. Same thing with misoprostol. I really don't use it. And then antacids, they're outdated. We don't really use them anymore. We're talking about stuff that's over the counter. Mylanta, Tums, Pepto-Bismol. I mean, patients have probably already tried this and it's not helping, okay? We already talked about H. pylori eradication. Talked about quadruple therapy, right? It can be kind of difficult to treat H. pylori. I mean, if you think about it, you need 4 drugs to get rid of it. So it's kind of a pesky bug to get rid of. But we do have pretty good treatments for it. Please refer to the previous slides for that. And then, of course, you do have ulcers that are not caused by H. pylori. And in that case, those are going to be these other medications, proton pump inhibitors, H2 blockers, and then there's also prevention of relapse, right? Very good. So these are, well, before we get into the complications, there is surgical management. It's rarely needed electively, but it's required for complications of peptic ulcer disease. So bleeding sometimes requires surgery. Perforation always requires surgery. And then sometimes you get these ulcers around here. So this is the outlet of the stomach. You get these ulcers that kind of scar down this area and make it bigger. And so you have trouble with food getting out of here because everything is kind of enlarged in this area. And that's gastric outlet obstruction. So let's talk about some of the complications of peptic ulcer disease. These are the things that we're trying to avoid by detecting this and treating the patients. Now, by far, the worst complication, well, it can arguably with GI bleeding, but perforation, okay? How does that happen? Well, right here, right? So the erosion erodes, and then there's no stomach left to erode through. And it bursts, and contents leaks into the abdominal cavity. You get this diffuse peritonitis. You get fever. The patient looks septic and acutely ill. They get peritoneal signs. They look really sick. Leukocytosis, fever, an acute onset of severe abdominal pain. Remember, peptic ulcer disease is kind of a chronic condition. So these patients kind of expect this gnawing type pain. But this is like, whoa, out of the ordinary, pops up. And you get peritonitis. They're hemodynamically unstable, low blood pressure, high pulse, fever. And this is where I was talking about getting that upright chest x-ray or acute abdomen series. And what you're looking for is right here. So you're looking for free air under the diaphragm. Okay, so the air bubble should not come up above the diaphragm. So you do have air in your gut, but this air should not come up above the diaphragm. There's not free air in the pleural cavity. Okay, so if you get free air up here under the diaphragm, that means that you have air that's leaked out of the gut somewhere, and that is a sign that you have a perforation somewhere. And it's not a good sign. In that case, you can get a CT scan. You're going to call the surgeon, and it's emergency surgery to close the perforation and antibiotics. And it can progress to sepsis or death if you don't treat it. So it's very, very important that we try to prevent perforation. If we find it, we treat it. Okay. Gastric outlet obstruction we talked about, where you get these ulcers that kind of cause kind of swelling in that area. It's most common with duodenal and type 3 gastric ulcers, and the stomach just can't really empty as well as it could before, and patients get kind of early satiety. GI bleeding. GI bleeding can be slow, like kind of over a period of time, or it can be rapid. If you get a quick erosion through, it can lead to shock, so it can be life-threatening as well. And peptic ulcer disease is the most common cause of upper GI bleeding. Okay, so these patients that have GI bleeding, which we have a separate lecture on, but they require resuscitation. So you got to figure out, you get fluids in them, get a type and cross for what kind of blood type they are, get units on board if needed, and you need to figure out where the bleeding's coming from and try to stop it. All right, this is one of my favorite little med comic ones, because this little H. pylori is just so cute. It talks about risk for gastric carcinoma, it talks about precursor for gastritis and peptic ulcers, and talks about urease for urea breath tests. And then the treatment here, I had to change it. I'll be honest, I had to change it. It had triple therapy, but I changed it to quadruple, and I added this lovely guy in here. So if you have the original, this is not the original. I took the liberty of adding him on there. So we added him on there. Now, towards the beginning of talking about ulcers, I mentioned the difference between duodenal and gastric ulcers. This is really kind of more of an academic assessment, not really useful clinically, but it's worth looking at. We kind of mentioned it before. The pathogenesis of the H. pylori, remember we said it's more common in duodenal than gastric. Malignant potential is more so with gastric ulcers than duodenal ulcers. There are different types of gastric ulcers. Type 1 is the most common. It really just depends where it's found. I'm not too keen, or there's 4 types actually, but I'm not too keen on you knowing the different types of gastric ulcers. I don't know that the age is really that important either, but there's also an association with certain blood types and risk factors for them. But this chart is more of an academic approach rather than clinical. So I want to mention it because classically and historically there has been kind of a differentiation between duodenal and gastric ulcers, but actually it doesn't really matter. Okay. Next up is Zollinger-Elison Syndrome, or a gastrinoma. We're going to cover this really briefly because it's one of those things you're probably not going to see very often, but you want to know it exists, because you're eventually going to have that one patient that's refractory to treatment. You're going to be like, what the heck? Why can't this patient get better with PPI? Why do they keep getting these peptic ulcers? And you got to remember that Professor G told you way back when that Zollinger-Elison syndrome exists. Okay. Usually they get acid hypersecretion, and they get peptic disease, and they get steatorrhea, or poor malabsorption. They usually develop between the ages of 20 and 50, more common in men than women. These patients develop recurrent and refractory peptic ulcers. So that's what you're looking for in a vignette. A patient has had multiple episodes of GERD or peptic ulcer disease that does not get better with any treatment. Okay. They also get some abdominal pain, chronic diarrhea, heartburn, weight loss, and GI bleeding. You should suspect it in patients that have multiple or refractory duodenal ulcers or ulcers distal to the duodenum. You diagnose them. The best initial test is to do the fasting serum gastrin. That's the one that we do. That will help you determine whether or not we have this type of tumor, and it can be malignant. Okay. Medical management, you want to limit manifestations and complications of peptic ulcer disease by doing PPIs, and then most of the time you have this sporadic gastrinoma, and hopefully you can go in and remove it. If it has already metastasized, then it is very difficult to treat. So that's just something to mention here. And you can see there's the tumor, okay, leading to hyperactivity. Here's just some little images of gastric ulcers. So there's some little ulcers here. You can actually see them on x-ray. This is barium. You can see them. Here's another barium x-ray with a duodenal ulcer. You can actually see it there. And some other ulcers on endoscopy that you can see. That's kind of what they look like. Kind of remind me of the ulcers you get, like aptus ulcers that you can get in your mouth. I don't know if any of you ever had an ulcer kind of in your mouth, on your oral buccal mucosa. Kind of look like that, right? And then there's a duodenal ulcer on endoscopy. Now, certain ulcers can become malignant, can cause cancer, but you can't always tell that with the naked eye. You do have to get biopsies. And that leads us right into gastric neoplasms. Now, we are not going to talk in depth about all the different types of gastric neoplasms. We're just going to touch on it briefly. The major type of gastric neoplasm is going to be an adenocarcinoma, similar to the adenocarcinoma that we can get in the esophagus. Gastric cancer is actually really rare in the United States, and it's much more common in Japan and the neighboring countries over there. This is more patho-y, but there are different morphologies or different morphologic types. Ulcerative, polypoid, superficial spreading, which is the most favorable, and then the worst type would be this linitis plastica, or this leather bottle, where the stomach wall becomes really thick and rigid, has a very poor prognosis. So what are some risk factors? Well, H. pylori. 60-90% of gastric cancers are caused by H. pylori. And then having these little polyps, chronic atrophic gastritis, pernicious anemia. We also have the Menetrier disease, which causes this like hypertrophy of the inside of the stomach, where the stomach kind of looks like the brain. It's really uncommon, but something that I know is mentioned from time to time. Also, different diets like high salt, nitrates, nitrites, smoked fish, and then for some reason blood type A is more common to cause gastric type cancers. So clinical features, generally asymptomatic. Let me change my pen here. And then the typical symptoms of neoplasm, so unexpected weight loss, some epigastric type pain, reduced appetite, anorexia, dyspepsia, early satiety, and then nausea, vomiting. Sometimes you can get guaiac positive stools or melena, anemia from chronic blood loss and erosion. Here's some of the causes of gastric cancer. How do we diagnose it? Well, the most accurate test is going to be endoscopy. With multiple biopsies, it sometimes can be really hard to biopsy gastric neoplasms. So you want to get multiple biopsies from different parts of the stomach. After the diagnosis is made, then you want to do a more extensive neoplastic evaluation, including a CT, chest, abdomen, pelvis, looking for staging and detecting presence of metastases. And then we tend to do this EUS. It's actually better at telling us better than a CT at telling us the depth of the tumor and the penetration of the tumor. So with that, you do endoscopic ultrasound, and it tells you kind of how deep does this go, where does it travel to. And then also in diagnosis, before any of this even, we can do a fecal occult blood to look for like chronic blood loss that we can't see with our naked eye. Surgical resection, you can do a surgical resection or a gastrectomy, subtotal or total, taking the stomach out with or without lymph node dissection, and plus or minus chemotherapy. That's pretty much the extent that I want you to know for gastric cancer. Here's some different images of gastric cancers. Early gastric cancer could really just show some histologic changes, so that's why it's really important to get biopsies throughout. Whereas you see ulcerating adenocarcinoma, and then these masses that you can see there. And then this is that Linitis plastica, the leather bottle, where the entire wall of the gastric wall is thickened, and you can actually see it on CT here, and it's essentially called this leather bottle. Okay. And here's another CT image of a gastric cancer that you can see there. Last but not least, we are covering gastroparesis. So just like the name says, gastro is in the stomach, paralysis, is going to be slowing or paralyzing, right? So decreased activity, okay? So gastroparesis is a syndrome of delayed gastric emptying. So we eat food, it goes down our esophagus, it makes its way into the stomach, and then, like we said, it sits there for a while and it churns, right? Well, then little by little, the stomach empties, right? It sends a little bit on once it's digested, and a little bit on, and a little bit on before it completely empties. Now, in some cases, you get delayed gastric emptying, where that stuff never leaves the stomach. It stays there. And it's tend to be caused, mainly idiopathic, but there's other things that can cause it. It's basically the nerves in and around the stomach are not working as well. And the way I like to think of it is like diabetes. So if you think about diabetes, your nerves, you get peripheral neuropathy. Your nerves just don't work like they should. Same thing in the stomach, right? They just don't work well. They don't churn the stomach as well. So things just kind of sit there. And so these patients can be quite uncomfortable after they eat. Can also get it after surgery, especially like gastric bypass and things like that. Nausea, vomiting, abdominal pain, and early satiety, postprandial fullness, so they just eat a few bites and they're already full, and a lot of significant bloating. And eventually weight loss, because these patients can't eat as much, they get full really quickly. And I saw this so many times in the GI clinic, and it's hard to diagnose because you can't diagnose it unless you do a gastric emptying study. And so you should suspect this. If you see patients that just have this, oh man, they skip full so easily, they have recurrent nausea and vomiting, bloating, you should definitely consider gastroparesis, especially in the setting of diabetes, which is very prevalent down here. Okay? Now, before we can go blaming it on gastroparesis, we have to exclude mechanical obstruction. So we have to go in and look with an endoscopy, and that's going to help us know that we don't have some sort of mass or obstruction that's preventing the food from leaving the stomach. On top of that, then we do what's called the gastric emptying study, and we did many of these, or we ordered them. It's a kind of a nuclear medicine study where they put this radioactive material, and usually use like egg whites, and they have the patient eat, and then they scan them at intervals of time. So they scan them at, so right when they eat, then they scan them, certain amount of time later, and a certain amount of time later, looking at how much of this material has left the stomach, how much has emptied out of the stomach. And in patients with gastroparesis, you will see delayed gastric emptying. Okay. What do we do? So initially we do the same thing, dietary modification. We want to get their glycemic control under control, especially with diabetes, keep them well hydrated. And sometimes patients even have to go on full liquid diets to try to prevent the gastroparesis. If that doesn't improve, the number one go-to drug is Reglan. But as Dr. Posable mentioned, you do have to be careful with Reglan because you can get dyskinesia and things, very severe side effects. You have to monitor them closely. And then surgery, we rarely do it, but refractory cases might require surgery. Also, try to get patients to avoid foods that are hard to digest, like broccoli and black beans and things like that. And we also don't recommend like fatty foods, acidic foods, spicy foods. And there's a syndrome that kind of goes along with gastroparesis. It's the cyclical vomiting syndrome. So that can be kind of hard to differentiate between gastroparesis. Cyclical vomiting, I tend to see in the ER with chronic marijuana users. They just get these violent episodes of vomiting, and then long periods, stretches of time, months, with no symptoms, and then all of a sudden cyclical vomiting. And it can be due to other things, but that's just something I like to mention when I talk about gastroparesis because they can look really similar, since nausea and vomiting are pretty prevalent symptoms with gastroparesis. Anyways. That's what I got for you. That's the stomach. We talked for quite a bit of time about it. I think we covered a lot, and we tend to repeat ourselves quite a bit. I think we could tell that a lot of these diagnoses overlap each other in terms of clinical presentation and workup and treatment. So that's good. You know, it's really good for us because you can tell that it's actually quite difficult to differentiate them. But the good thing is we do the same thing for most of them, and most of them get better. So that's what I got for you. Thank you for tuning in, and I will see you next time.